Good evening, everyone. As we've been doing, so we have been handling LV segmentation, but of which the most important thing is to quantify LV function. To quantify LV function, either systolic or diastolic, depending on wall motion abnormality, the region wall motion abnormality of the LV, of the left ventricle. So we have been handling 17 segment model, and I believe we're almost done. So whatever is remaining is actually to show you the segments on the real echo. So this is an example of wall motion abnormality. Why we are doing the LV segmentation? It is to quantify wall motion of the left ventricle, and this is the video showing an example of wall motion abnormality in a patient who has ever suffered a myocardial infarction. Again, as I've been saying, that in each and every echo, I normally start with the parasternal long axis. In this particular subject, we didn't, or person, the parasternal long axis view was not all that clear, but whatever we can see is a hypokinetic, is a normokinetic posterior wall or posterolateral wall here. It's almost normokinetic, and if you see the anterior wall, or that is anterior septum, it is almost not moving. And again, when you look at it, this is the pericardium here. It should be bright as it is, but again, now see the septum here, this part here, this particular part, it is as bright as the pericardium. If I try to reduce on the brightness or the gain, it will still be bright. Here the posterior wall, which is normal, it disappears, and only the pericardium remains to be seen. And here in the septum, the muscle disappears, but where there is fibrous tissue or kind of scar, it keeps, or it remains bright. So this indicates a scar here, a scar tissue here, like in the pericardium. So this is hypoechoic, and also here hypoechoic. So scar tissues in myocardium, they are seen as hypoechoic structures. So in this particular person, it is hypoechoic segment here, but again not moving as compared to the posterior wall, not moving. We are going to confirm that. It's not moving, and this is the M-mode line that is cut at the level of left ventricle at the tip of the mitral valve. If you clearly see the M-mode, the posterior wall or posterolateral wall, it is moving. That's why it is wavy. This is diastole, systole, diastole, systole, diastole, systole. This is how it should be. Same thing should be reflected this side of the septum. But now we see this hypoechoic segment here, line. The scar tissue, it is continuous, and if you check on the movement is not all that good. This anterior septum is almost thinned out. From measurement, it was 0.6. It was almost 0.6. So it's almost thinned out, scarred and almost thinned out. Severely hypokinetic or even akinetic. The kinetic means it's not moving. Hypokinetic means it moves but less. So this one is almost not moving. We can clearly say that it's a kinetic or severely hypokinetic in this segment compared to this side, to the posterior wall. It is moving, but this one is always flat. Yeah. When you check this short axis here, you see, remember from the handwritten notes we've been sharing, we were saying that this, the short axis view at the level of mitral valve, that is the base, where we have the anterior wall, inferior wall, the lateral wall, and then the septum. The septum has anterior septum, inferior septum, inferior, inferolateral or posterolateral, anterolateral, and then the anterior wall. So when you see clearly this side, you see the endocardium. Now to check for all motion abnormalities, we have to see the endocardium, endocardial excursion. In cyst 3 and diastole, don't look at the entire wall, you just see endocardium where it is going. In cyst 3, it should move inside, diastole, it goes out. So if you see here, from around here, here it is moving very well, and here, moving very well. So this segment is moving, but from here up to this side, it is not moving. Here it is not moving, here it is just hypokinetic, here. So hypokinetic, when you compare, we have to compare to other segments. So we are comparing with the inferior wall, we are comparing with the lateral wall, we are comparing the anterior and then the septum. So clearly if you compare here and anterior and inferior, this one is moving and this one is not moving. So that is a regional wall motion abnormality at the level of anterior, at the level of base. The segment is anterior. So here, the anterior wall or anterior territory is akinetic at base. Because remember, that's what we said. We said we divide the left ventricle into base, mid, and then apex, or the apical. And then here, this is the short axis, mid, LV. This is mid LV, and now again check. It's not moving. Here it's not moving completely. Here it is hypokinetic, and then this side, the inferior wall and the posterolateral wall moving very well. So this one is moving, this one is not moving. But again, remember the tethering effect. The tethering effect is affecting the anterior septum and then anterolateral. They are being tethered. They are being pulled by the neighboring moving myocardium, or they prevent the neighboring normal myocardium to move, because for them they are not moving. But in general, the anterior wall is not moving. From the base now to the mid, let's see what is happening to the apex. Okay, near the apex, the inferior wall is moving, and the anterior wall akinetic. So in general, we can say this is, in this echo, there is a wall motion abnormality, which we can summarize as anterior territory akinetic at base, mid, and apex. Anterior territory akinetic at base, mid, and apex, or anterior wall akinetic at base, mid, and apex. Anterior wall has anterior septum, anterolateral, and then anterior itself. Otherwise, you can mention them like separately, like anterior septum, anterior, and the anterolateral walls, akinetic at base, mid, and apex. This is a patient who had PCI in 2019. So that's how we can summarize. I'm just showing you the wall motion abnormalities. We are going to see more views. The views were not clear, the windows were not clear on this patient, but this is an example of wall motion abnormality. This is apical 3 chamber. This is apical 3 chamber. This is a left atrium, mitral valve, left atrium, mitral valve, aorta, and then LV. You see, so apical 3 chamber is like parasternal long axis. So this is anterior septum here, and then this is posterolateral or inferolateral wall. So you can clearly see that inferolateral wall here, it is moving. Inferolateral wall is moving here, you can see. Not a good one, but you can see. And then we have a moderate MR, mild to moderate MR. mild to moderate MR with mild calcification of the mitral leaflets. You see, I'm confirming whether there is calcification or not. You see the tips of anterior mitral leaflet, posterior mitral leaflet. So check the anterior mitral leaflet, the tip. It is bright, and if I try to reduce the gain, it continues. You continue seeing it. Other structures disappear, but here, for it remains, meaning that is calcium. And also the annulus, the posterior wall, some mild annular calcification. You can see here that this is fourth chamber. Fourth chamber, I have anterolateral, inferior septum. So you can see here that inferior septum is moving and anterolateral is moving. Inferior septum is moving. Anterolateral, we're not sure because of the view, but from the short axis it was not moving well, but here it appears to be moving. So this is inferior septum, is moving very well. Inferior septum here is moving, but anterolateral here, we are not sure because of the window, but from the short axis it was hypokinetic, severely hypokinetic. And then our MR is there. Now again, remember that we said we do the segmentation of the LV depending on coronary artery supply. So when I use the word territory, I mean the territory supplied by a particular coronary artery. Remember, coronary arteries, we have two main ones, RCA and the left main. Right coronary supply, right coronary artery supplying the right ventricle, and then the inferior part of interventricular septum. It is supplied by the right coronary artery. And then we have in right dominant patients whose coronary supply is right dominant. Right dominant, it means there is a posterior descending artery, in which case it can be a branch of LCX or a branch of RCA. 95% of patients, it is a branch of RCA. They are right dominant. So in right dominant people, the RCA giving rise to posterior descending artery. The posterior descending artery will supply the inferior wall of left ventricle. The inferior wall of left ventricle will be supplied by RCA. So in cases where RCA, let's say mid RCA, is occluded, we expect the inferior wall to be hypokinetic or akinetic, or to exhibit wall motion abnormality. That is in right dominant patients. And in those ones who are left dominant, that is where the PDA, we normally call it PDA, posterior descending artery, is a branch or originates from LCX. That LCX will be supplying the inferior wall of left ventricle. So in cases where maybe proximal LCX is blocked and the circulation is left dominant, we expect hypokinesia or akinesia in inferior wall of the left ventricle and also lateral wall of left ventricle. We expect, because we know that is those are the territory supplying. Now, in cases where we have LAD occlusion, we expect the anterior wall, because LAD runs on the anterior aspect of the left ventricle. So we expect the anterior wall to exhibit wall motion abnormalities. And then the anterior septum, because the LAD gives different branches. It gives branches to left or to the lateral wall, that is in form of diagonals, and then it gives branches to the septum. Those are septors. Those septors supply the anterior septum. The inferior septum, we said, is RCA. Now the anterior septum is LAD. So if LED is occluded and part or before the septal branches, then we expect wall motion abnormality and the anterior septum. That's why we had to divide these walls into different segments, because they are supplied by different coronary arteries. And then the anterior walls, the lateral walls, anterolateral, for example, if there is occlusion before diagonals, then anterolateral walls will be hypokinetic. It's simple as that. It is so easy for wall motion abnormalities. You have to read. I'll make a clear video about this one. It is just that this one I wanted to show you how wall motion abnormalities look like. Maybe in the future, when I get a good window, someone with a very good window, I will show you very clear images. Yeah.